So we're going to get started on the webinar today. It is specifically on rotator cuff tendinopathies. I think I labeled it tendonitis, but really I'm going to talk about really what's referred to as a group of conditions called tendinopathies of the rotator cuff. Remember that all of my webinars are recorded, which means that we will send out a follow-up email within a week or so, and you'll be sent out a link to watch the webinar if you do want to watch it again, or if you had to leave early, or if you register and you can't tune in, you'll still get that email. So that's always comes in handy. I get emails all the time asking if you can watch it again, and you can. You just have to subscribe, like you have to register for it. If you have our equipment, then these webinars are posted on our support page, but that support page is only accessible if you have our equipment. So if you don't have our equipment, then the only opportunity to watch it again is via that email. So if you have any questions as we go along, that would just type them in, specifically about this webinar, and at the very end there'll be a chance for a Q&A as well. So that's kind of it as an intro. I'm the Director of Education and Research here for Meditech. I'm a chiropractor. I've been practicing almost 25 years. I've been working here and specialize in photobiomodulation for the last 10 years. And I work in our clinic, our large outpatient clinic, as well as helping out with research and training and education and so forth. So my goal today is to briefly go over and review the musculature, anatomy, and definition of tendinopathy. We'll talk a bit about etiology and pathogenesis and some of the standard ways of assessing and treating rotator cuff tendinopathies. And then I'll get a little into some of the research on low-level laser therapy or photobiomodulation and this condition. And then I'll talk a bit about how you would use our equipment to treat this kind of condition as well. And then lastly, I have a case study that I'll present as well too. And then we'll have time for some Q&A. So everyone is familiar, the rotator cuff are the sits muscles, subscap, infraspinatus, supraspinatus, and teres minor. Of course, they originate from the scapula, inserting into the lesser and greater tubercles of the humerus. The tendons cross the shoulder joint and blend in with each other and the joint capsule. Of course, we know where all these muscles are. There's no surprise here. Yeah, we'll move on from that. So these muscles, as you know, help stabilize the glenohumeral joint. They aid in abduction, internal rotation, and external rotation. Tendinopathy of this rotator cuff is one of the most common causes of shoulder pain. So it's one of those things that you tend to gravitate in your differential diagnosis when a patient is suffering from shoulder pain. Specifically, the supraspinatus, as you are well aware, it's quite uniquely susceptible to compressive forces of subacromial impingement. The tendon itself has poor vasculature, and because of the weight of the arm tensions the tendon, it tends to have even poorer blood supply. So it's more prone to degenerative changes of the tendon over a period of time. Things like improper, athletic technique, poor posture, poor conditioning, issues with the subacromial bursa. These can cause inflammation. Of course, we know there's calcification that can occur as well. There can be degenerative thinning around the joint, and of course, it can be tears of the tendon. Most commonly, degenerative tears as we get older, whatever older is, I guess, nowadays. The rotator cuff disorders are a fairly common problem. They account for, according to the literature I've quoted below, to roughly 2/3 of all shoulder cases. And oftentimes you'll see the terminology subacromial impingement syndrome, which is kind of a catch-all phrase for rotator cuff tendinopathies. Essentially, it's believed that acromial irritation itself is not the primary cause of the symptoms. From this research, they say that about 50% of all patients or more diagnosed with rotator cuff tendinopathy seem to be fully recovered within the first year or so. And this indicates that it's a long-standing condition, oftentimes not overly self-limiting, which means that you need to treat it. patients coming in with rotator cuff tendinopathy will not usually get a lot better in a week or two, right? So this is a condition that you have to lay out an appropriate treatment plan for, understand the degree of degeneration or issues that you're dealing with in order to come up with an effective treatment plan and, of course, a fairly accurate prognosis. The hallmark of rotator cuff tendinopathy, as we all are aware, is, of course, pain and weakness, especially with external rotation combined with elevation. So like reaching overhead in the cupboards, that kind of thing, or reaching behind your back. I had a patient the other day that I was treating for low back pain, and she mentioned that she was putting her arm behind her back to just unclip her bra, and right away she had some issues with her shoulder. So it's pretty common. Assessment is relatively complicated because the clinical tests are oftentimes not overly specific, and there seems to be poor correlation between structural failure and the symptoms. In other words, it's hard to really isolate what's going on even with orthopedic tests. So the principal guiding treatment for rotator cuff tendinopathy, essentially, as we know, is resting the patient, modifying their painful activities, whether it's at work or play. Sometimes you pull in exercises as long as they don't exacerbate the pain. You need to control reloading of the tissues and gradually progress the patient from simple to more complex shoulder movements as they're progressively getting better. The definitive cause of this condition is still, believe it or not, relatively uncertain. There's really a poor understanding of the source of pain in rotator cuff tendinopathy. There's different proposed mechanisms that oftentimes are referred to as either intrinsic or extrinsic, or a combination thereof. Extrinsic means things like reducing the strength of the tendons due to, say, contact excessively with structures like the humeral head, weakening or poor functioning of musculature, fatigue, pain-related inhibition, so structural incompetence, so for example, reduction of the subacromial space. When I'm referring to intrinsic mechanisms, that's more things like aging and genetics and vascular changes, altered loading patterns, that kind of thing as well. Excessive tissue load is considered to be the most common factor in the development of rotator cuff tendinopathy, and it's reflected by the fact that it occurs more frequently in the dominant limb as opposed to the non-dominant limb with respect to occupation and sports. So anything where a patient is repetitively doing high rates of upper limb loading, tennis or squash, or loading stuff at a dock or whatever it is. These are the things that are going to predispose that patient's arm to this type of condition. Underloading may also disrupt the tendon homeostasis, and it may also potentially result in temporarily earlier point of failure when the tendon is subject to load. So in other words, if someone doesn't use their shoulder very much and doesn't load and do exercises, they oftentimes are prone to having failure and tendinopathy just because it's not being used very much. Other lifestyle factors like obesity, metabolic syndrome, smoking can also increase the risk and also can delay the recovery of this tendinopathy. There are a significant proportion of individuals with this condition that have pain that radiates down the arm. It may even have hyperalgesia to pinprick stimulus of the skin. So make sure you ask about radiating pain. Yes, of course, differential diagnosis would be like a C5 or C6 nerve root impingement, so you need to check out the neck as well. But don't be surprised if, in fact, the pain is radiating down, and it may be subsequent to this condition. There may be thoughts of central sensitization going on as well. So this is important because if you have central sensitization, you'll want to treat the neck as well as the shoulder itself. We all know that a special orthopedic test designed to assess the integrity of the rotator cuff. You're looking for reproduction of pain and looking for weakness during these somewhat non-specific diagnostic tests. So, what you're trying to do here is you're trying to, come up with what you feel is somewhat, somewhat certainty and confidence that the patient does have an issue at the rotator cuff. Of course, imaging would be very helpful here, but that's not always possible. So, oftentimes you're going to treat it as a rotator cuff issue, and if it's quite severe, the symptoms are severe, long-lasting, you might want to at least do an ultrasound to see if you can get a better idea of what's going on. There have been quite a few imaging studies that have reported, in fact, that there can be substantial shoulder tissue structural abnormality, yet no shoulder symptoms. So in other words, a person might have shoulder pain and they might have structural abnormality, but it's not the cause of that shoulder pain. So these patients are wheeled off into surgery, and in fact, they may not even need that surgery. So before that patient gets rushed off to surgery or they're keen on surgery, then just beware that it may not actually be the cause of the problem. There is actually a fairly good body of research, scientific-wise, on peer-reviewed articles on photobiomodulation and rotator cuff. This particular paper I've noted below looks at the effects of combining standard physiotherapy management along with low-level laser therapy. So they either did it together or in or just a physio, and they want to see which was better. So they looked at 25 patients in a control group. The control group had the standard physiotherapy treatment, so superficial heat, deep heated therapy, which they referred to as ultrasound. So that would have been a continuous wave ultrasound. They used TENS or IFC or something along that nature, and an exercise program, and they did 10 sessions. So they did the same thing in the experimental group, but they added low-level laser therapy to 25 patients. So you have your control group and you have your experimental group with laser therapy. They used 830 nanometers. Remember that near infrared is going to penetrate deeper in the body, so you'll want to use near infrared if you're trying to get into the tendon and deeper structures. They used 100 milliwatts, energy density 4 joules per centimeter squared, and it was a continuous wave is what they used. A surface area of the probe was 1 centimeter squared. So comparison, our laser probe at BioFlex is 0.1 centimeter squared. They irradiated for 20 seconds irradiation of each point. They did at least 5 points. They did at least up to 10 painful points, and for up to 5 minutes of total treatment time. So these were the results. They looked at changes, the mean changes of variables that they were assessing. I'm going to point out that one of the key things they noticed was the experimental group that had laser therapy, the visual analog scale or the pain scale dropped by just over 4 points, whereas a control group, it only dropped by about 2.5 points. So there seemed to be a significant improvement when you added laser therapy for pain. And then when you looked at the number of shoulder functional problems, the ranges of motion increased compared to the control group when you added laser therapy. So generally speaking, when they added laser therapy to the standard physiotherapy, the results were better. So in other words, these positive objective signs were much improved with this experimental group that had laser therapy. So they concluded that low power laser therapy combined with conventional physio was superior over just generalized physiotherapy, especially with respect to helping with pain and improving the patient's function. So the takeaway here is that laser therapy acts synergistically and acts differently than those other types of therapies that we would standardly use, whether it's manual or other electrotherapeutic modalities. So when you add it in, you will definitely see an overall improved outcome. This next paper was a systematic review with a meta-analysis, and the primary outcomes they were looking for, again, was visual analog scale pain and relative risk for global improvement. They looked at an overall 17 RCTs that met the inclusion criteria. And when they looked at the statistical analysis of laser therapy, They showed that it helped reduce pain, accelerated the improvement with respect to when it was used as a monotherapy or as an add-on therapy, as I just mentioned in the previous paper, to a physiotherapy treatment regime. So except for laser therapy alone, there was no strong evidence for an effect of shoulder function was found. So in other words, they did find that laser therapy was quite beneficial. They concluded that optimal laser therapy can offer clinically relevant pain relief and initiate a more rapid course of improvement, both just on its own as a monotherapy and in combination with physiotherapy interventions. They mentioned here, it was interesting that these findings actually challenge the conclusions in other multimodal shoulder reviews of physiotherapy and their lack of intervention quality assessments. In other words, this particular paper kind of challenged the thinking that other reviews where they talked about physiotherapy modalities and their effectiveness, perhaps we need to revisit that as far as adding laser therapy to the mix. This was a randomized controlled trial of 80 patients. They were diagnosed again with subacromial syndrome, or again underlying rotator cuff tendinopathy. It was an RCT double-blinded control trial. They looked at 40, in group 1 there were 40 patients that received laser therapy and exercise for 10 sessions over 2 weeks. So that was about, I guess, 5 sessions a week. And in group 2, it was a placebo laser along with exercise therapy over the same time frame. They used 890 nanometers. That's getting a little high, but still I think would be effective. It certainly will go deep, or relatively deep. They mentioned something about a pulse mode, but they didn't actually say what the pulses were, so I have no idea. In each of the treatment sessions, they chose 3 points, including anterior around the coracoid process and posterior over the GH joint and laterally over the actual rotator cuff tendon. And they were irradiated for 2 minutes for a total of 6 minutes. I don't recall seeing the actual power or the energy density in this paper. So they concluded that laser therapy combined with exercise is more effective than just exercise therapy alone in relieving pain and improving shoulder joint range of motion and in patients with subacromial syndrome. Okay, so these I do 2 types of webinars a month. I do a webinar a month on a specific condition and using our equipment by healthcare professionals to treat these conditions. That's what I'm doing today. I also do a webinar on using our personal systems, more geared towards the general public, but of course, professionals tune in as well. So I'm assuming that many of you out there have our equipment or are interested in our equipment or what have you. So those of you who have our equipment are familiar with this. That is a protocol. And the protocol for rotator cuff tendinopathy is frequency-wise in the first kind of stage is fairly low. You can start off with 10 or 20 pulses per second. So that's a fairly low stimulation rate. And that's infrared, and we use maybe 40, 50, 60% duty cycle. The red, we start a continuous wave, and we'll generally speaking treat the anterior aspect of the shoulder, lateral aspect of the shoulder, and posterior aspect of the shoulder. We use the laser diode infrared. It says 200 milliwatts, but we actually will set it at probably 30 or 40% power, and we'll choose different points along the shoulder to treat as suggested in the research. And then as the patient's progressing or plateauing, we'll start to increase frequency rate and increase duty cycle, and finally into stage 3. So we'll start pretty low, see how the patient responds over several sessions, and we'll start to increase frequency and duty cycle by 10, 20 hertz at a time, 10-20% duty cycle at a time as well. So here are the positions of the array. You can see it overlying anteriorly, the red light's on. Remember, red light does not go very deep. Essentially, I mean, it looks really bright and everything. It is going to have a major impact on the inflammatory or the anti-inflammatory cytokines being secreted by the white blood cells overlying the shoulder joint. So we place it anteriorly, we'll place it laterally, we'll place it posteriorly. And the goal here is to induce an anti-inflammatory effect in and around the shoulder joint and the rotator cuff tendons that are involved. When the red light turns off, it goes into infrared. This infrared light, again, will penetrate deeper, getting some of the deeper structures, but also gearing towards the blood, especially the deeper blood that's circulating into the musculature and the tendons involved. Each one of these placements will be in place for about 10-11 minutes before you move it to the next position. Notice that we keep a weight, or you could strap it into position. The idea here is that you want to make good surface contact with the diodes on the skin to ensure that the light is actually going into the tissues as deeply as possible. This is a hands-free portion of the treatment, so you don't need to attend to the patient, and the patient does not need to wear safety eyewear because it's incoherent or non-coherent light. So you want to treat around the entire shoulder joint. Remember, start with a fairly low frequency and duty cycle. We do find that sometimes patients with rotator cuff, especially if it's an acute scenario, like a tendonitis scenario, they are sensitive, so you want to make sure everything's pretty low. Remember, have realistic expectations. Your patient's aren't going to get remarkably better in a few sessions. Usually, it's going to take quite a few sessions. Of course, you're going to add manual therapy and exercises within the patient tolerance levels. And remember, you may want to look at the cervical spine, especially if there's central sensitization or if you suspect issues with the neck as well. So treat both proximal and distal trigger points. Remember that you're stimulating both the anti-inflammatory process with respect to helping reduce inflammation, but you're also trying to promote tissue regeneration in the tendon and the other structures that might be involved as well. This is going to take some time to manifest as objective improvement. So again, you're going to lay out a treatment plan, and I'll have an example very shortly. Remember that treatment time must reflect the therapeutic dose of the tendon depth. So I'm going to suggest you at least start at holding the probe for at least 5 to 8 seconds per point, maybe even increase at 10 to 15 seconds if you're finding that not overly effective. You may also want to treat the axillary region to access the subscapularis muscle and tendon if you feel it's involved as well. Once all the points are treated, you can actually go back to the common tendon and treat that again. If you have the red laser probe, then you should use that as well too. It's very beneficial for stimulating, for helping with pain and helping with treating for anti-inflammatory effects of the blood. You may also want to place the glenohumeral joint in positions to increase exposure of the tendon itself to light. So in other words, if you adduct the tendon, it actually exposes the supraspinatus tendon, and you can actually get a little bit more light into the tendon itself. Okay, so we have 5 minutes to go over a case study. In this particular case, it was a 27-year-old personal trainer. They presented with obviously pain in the right shoulder. And the results have, this patient was bench pressing at fairly high levels. And so the symptoms started over 1.5 years ago. And this is not uncommon to see patients that have lingering pain in the shoulder because it just hasn't healed. Obviously, there was issues with restricting physical activities. They were using ice, they tried heat, analgesics, IFC. Nothing was providing overly long-lasting effects. Upon palpation, there was pain over the deltoid, the long head of the biceps, supraspinatus tendon, and shoulder joint. I should mention that I think about 1/3 of the cases of rotator cuff pathologies have biceps involvement. So make sure you assess the biceps tendon as well and treat it if it's also affected. The patient had some limitation in ranges of motion as well, especially with lateral abduction and posterior extension. They did an ultrasound, and the impression of the ultrasound, in fact, there was some calcific tendinopathy as well as some biceps tendinosynovitis. So no tearing, but because it was long-standing, there was some calcification. Probably you're aware that when the body starts to resorb the calcification, that's when it's very, very, very painful. Laser therapy will not have any direct effect on calcification, but it will help with the inflammation that's being induced by the calcification resorption. The treatment plan initially the first week, especially because they were quite acute, was 4 times in that week, and the second week was 3 times, and then into third, fourth weeks was twice a week. We added some manual therapies and exercises into the third and fourth week as well, and some other general activities as they were improving. So initially, you can see the parameters. We started at 20/60. You know, we're sometimes a little bit more liberal with the protocols and start a little bit higher in the stage 1 as opposed to the lower end of the stage 1. The patient was able to tolerate the 20/60, so we did that. Notice the probe was set to 40% power for the LDI 200, and that's roughly 75 milliwatts as opposed to 200 milliwatts. And we used the red probe at 100%. Again, the red isn't going to go into the tendon, but it will have a very good effect at analgesia and for pain relief as well. So October 24th, this was after 3 treatments. We did the 4th to 15th treatments at this protocol. We started to pulse out the red light a little bit at 190. We went up to 70% duty cycle for the infrared, 100% for the probe, and you can see that we did quite a few sessions at this sort of maybe stage 2 kind of scenario. And outcomes, we had fairly good outcomes, 15 treatments in. That was about a month and a half or 2 months of treatment. They were subjectively reporting significant improvement with respect to pain. They were still obviously having issues, but they were feeling a lot better. They were able to resume some regular activities of daily living with respect to occupation and actual occupation as a personal trainer. We did continue to do some maintenance laser therapy during even post 90% improvement because we were targeting this calcification and helping with reducing that inflammation, maybe even stimulating the body to do that a little bit faster as well, but especially with helping with tissue regeneration. Maintenance-wise is about once a week in this scenario. Okay, so actually got through that pretty quickly today. I was pretty concise. So I do really appreciate you listening in. Let's just go over some questions that you have. So let me just get through this here. I do have a question here. During infrared, is the client required to wear protective glasses? The only time that we recommend wearing the glasses is when we use the class 3B laser, so the LDI 100 or 200. A question is it covered, is it FDA approved? Our equipment is FDA approved and Health Canada cleared and CE marked in Europe. Indu, you've asked a question about CPT codes. There are some CPT codes. If you care to email me about those CPT codes, I can certainly direct you as to what you might use. My email is david@bioflexlaser.com. So CPT codes are in the United States for insurance purposes. Let's see here. Do you recommend patients get imaging done before starting treatment? Oh, that's a really good question. I always say let's start treating unless we feel there's a contraindication. So as soon as that patient comes in, we'll start to treat, and oftentimes we'll give it a few sessions, see how they respond. But if I'm just thinking that it's really chronic and I'd like to see imaging, I'll get that going, but I will definitely start treatment even before imaging. I don't think it's really going to change how I treat unless they find something outside of the shoulder area that I'm not treating as well. Okay, those are the only questions I seem to have, so that's cool. I do have another question here. If a person experiences a stinger when raising their arm, would you treat in similar protocols? I think stinger, if they're receiving, like if they're feeling a sharp pain with certain movements, you're going to have to really figure out why they're getting a sharp pain. It's usually impingement, and that usually means that there's rotator cuff tendinopathy and swelling in the subacromial space. So, but you really have to figure out what's going on there. How would you treat the cervical spine if you think it might be involved in the right shoulder pain? So if I think there's some referral coming from the neck, or if I think that I want to treat the innervation supplying the shoulder, I'm going to treat the right. So in this case, for the right shoulder, I'm going to treat the right portion of the cervical spine. So instead of treating the entire cervical spine, I'll just treat the right side of the cervical spine, and I'll use a laser probe on the exiting nerve roots that will be supplying the rotator cuff muscles. When treating proximately, would you focus on T1 to C2? No, again, I think if I'm treating, I'm not sure I understand that question. So if I'm treating the neck, I'm going to treat the innervation of the rotator cuff musculature, which I believe is like C5, 6, 7. Can you combine with acupuncture for treatment? Yeah, I'm an acupuncturist. I'm a traditional Chinese medical doctor as well, and I've done a lot of acupuncture in my career. I do really find that acupuncture is very helpful in these cases as well. You can even do laser acupuncture as well. So Indu, if you had some specific questions more about that, please feel free to email me. Once again, my email, folks, is david@bioflexlaser.com. How would you alter this treatment for slap tears with rotator cuff? Slap tears are crazy hard to treat. So you're dealing with cartilage tearing. So it really depends on slap tear. I'm going to need to see imaging. And once you determine the injuring, the degree of the slap tear, then I'm going to have to understand my prognosis, because you may not get you may need surgery. But if it's a non-surgical case, then I'm just going to try to focus more light into the glenohumeral joint area, hold the laser probe for longer, and try and open up the glenohumeral joint to get light into that area and closer to the lesion. Heat or ice before or after laser therapy? Okay, so I would say if you want the light to go deeper, after you use the arrays, you can throw on some ice if it's inflamed, and then do the laser probe, and you get the light deeper. If it's a chronic scenario and it's more achiness and not a lot of acute issues, then do your entire treatment and then use heat afterwards. That would be my recommendation. Okay, listen, folks, thank you very much for joining me. If you have any questions, please email me and ask those questions. I do have a live online training in 2 weeks on Friday. So it's only $199 for an entire day of training. So if you haven't done our training, or you're interested more about what we do, it's a really good opportunity to learn more about photobiomodulation. Just go to our website, bioflexlaser.com, and go to events and go to training, and you'll see on Eventbrite how to sign up for that. Again, thanks very much for joining me. I do really appreciate it. We'll see you next time. Have a great day.